Welcome to episode 4 of fever. Now already we are discussing alteration in body temperature, and the first part is fever, and this is the last episode of fever. Before discussing today's topic, let us have a slight highlight of part 1, 2, 3. We have discussed already normal body temperature, thermoregulation, influencing factors, different sites where we will measure temperature. Then we have discussed different pyrogens, pathogenesis of the fever, and in last episode we have discussed approach to a patient of fever. Our today's topic is treatment of fever. Now, before discussing treatment, we will understand mechanism of action of antipyretics. So, we will today enter into our basic physiological discussion. Now, let us see fever. For fever, to understand antipyretic, we have to think where is the main problem. Main problem is the rising level of prostaglandin E2 in the capillary network surrounding the thermostat point, thermostat in hypothalamus. So, if we can reduce PGE2 by any process, then fever will come down because thermostat point automatically will come down. Now, how PGE2 is getting synthesized? From membrane phospholipid with the help of phospholipase A2, arachidonic acid is synthesized. From arachidonic acid with the help of cyclooxygenase enzyme, PGG2 and PGH2 is synthesized. From PGG2 and PGH2, different prostanoids are synthesized like prostacyclin, thromboxane, PGE2, etc. So, PGE2 basically is synthesized from PGG2 followed by PGH2. Now, PGE2 acts on 4 receptors EP1, EP2, EP3, EP4. Now, if we see when PGE2 attaches with EP3, cyclic AMP production rises and it stimulates nerve endings in hypothalamus, or rather thermoregulation center of hypothalamus, producing fever. What medicines we are using? Usually as an antipyretic we are using paracetamol, we are using NSAID, we are using steroid. These are important 3 antipyretic. Now, if we closely watch here, corticosteroid, that is glucocorticoid, it blocks phospholipase A2, So, arachidonic acid production is getting less, ultimately PGE2 synthesis will be less, automatically patient's temperature will come down. Glucocorticoid also acts in a different way. It blocks transcription of mRNA and ultimately production of pyrogenic cytokines. So, pyrogenic cytokines are proteins, they are produced by mRNA getting signal from the gene. mRNA transcription can be blocked by glucocorticoid. So, glucocorticoid acts in 2 levels. It blocks transcription of mRNA and it blocks phospholipase A2. Next is NSAID. If we think NSAID, there are 2 types of NSAID. One is selective another is non-selective. Suppose ibuprofen, non-selective NSAID, it blocks cyclooxygenase 1 enzyme, and automatically from arachidonic acid less PGH2 will be produced and less PGE2 will be produced. And if we use selective NSAIDs like any type of coxib, celecoxib, etorecoxib, any coxib, they block usually COX2. So, non-selective ibuprofen like that, they are blocking COX1 and COX2, and coxibs, they are blocking COX2. So, NSAID, if it is non-selective, they block both COX1 and COX2, and if it is coxib, they block only COX2. So, in that case, blocking COX1 and 2 by non-selective and blocking COX2 only by selective NSAIDs, production of PGH2 will be less and ultimately PGU2 production will be less and the temperature will come down. Now, the most important is acetaminophen or paracetamol, very common medicine we are using in our clinical practice. Even 100 years after discovery, for mechanism of paracetamol we have to know or we have to discover a lot, because it is yet not clearly known how it actually acts. Most common accepted theory is from cell membrane by phospholipase A2 arachidonic acid is produced, and from arachidonic acid with the help of cyclooxygenase PGG2 and PGH2 is produced. Now, for production of PGG2 and PGH2 there are two steps. First, from arachidonic acid PGG2 is produced, then from PGG2 PGH2 is produced. From arachidonic acid PGG2 is produced by the activation of cyclooxygenase site of cyclooxygenase enzyme. Now, cyclooxygenase enzyme has two sites of activation. One is cyclooxygenase site, another is peroxidase site, two sites. Now, when cyclooxygenase site is getting activated, PGG2 is produced. Then peroxidase site of cyclooxygenase enzyme is getting activated and PGH2 is produced from PGG2. What actually paracetamol does? It blocks peroxidase site, and for blocking peroxidase site, production of PGH2 from PGG2 is getting less and less production of PGE2. So, this is basically mechanism, one important mechanism of action of acetaminophen or paracetamol. For cyclooxygenase enzyme, there are usually two types of cyclooxygenase enzyme, COX1 and COX2, but there is one postulate where it is found COX3, another cyclooxygenase enzyme which is available in brain. Later on, from different studies, it is proven no, it is not COX3, it is another variant of COX1 which is mostly available in the brain, and paracetamol or acetaminophen acts on COX3 in the brain mostly. Now, the question is, Acetaminophen blocks cyclooxygenase, NSAID blocks cyclooxygenase, but we are getting anti-inflammatory property as well as antipyretic property from NSAID, but not from paracetamol. Why? It is found paracetamol acts better in central nervous system cyclooxygenase rather than periphery. Probably when arachidonic acid level is low, in that case paracetamol acts better. It is found in brain. From arachidonic acid less amount of PGG2 is produced, and in low level of PGG2 paracetamol acts better, and moreover COX-3 is available in brain, not in peripheral tissue. There are different other hypotheses: serotonergic pathway, cannabinol pathway. There are different pathways which also postulated for mechanism of action of paracetamol. So, in a nutshell, this is the mechanism of action of paracetamol, glucocorticoid and NSAID in fever as an antipyretic. Now, in any patient, usually we prefer paracetamol as an antipyretic rather than oral aspirin or NSAID. Reason behind: the side effects with aspirin and NSAID is more. So, paracetamol is far more safe. Moreover, in children, aspirin causes Reye's syndrome. So, for that reason it is better to use paracetamol. If patient is unconscious, in that case we can use IV paracetamol or paracetamol suppository. Sometimes NSAID suppositories are also used. Apart from glucocorticoid, paracetamol, NSAID and ecosprin, there are few anti-cytokines which we can consider as antipyretic in few diseases. As an antipyretic, apart from acetaminophen, aspirin, glucocorticoids, NSAID, sometimes in autoinflammatory syndrome, which is mainly interleukin 1 beta mediated febrile episodes, in that case we can use anti-interleukin 1 like anakinra or canakinumab. These are two anti-interleukin 1 drug, but it is found even though these auto-inflammatory processes are interleukin 1 beta mediated, in these cases antipyretics work well. The last part, it is very important to use antipyretic in few situations like patients having CNS disease, pulmonary disease, heart disease, where it is found rise of 1 degree centigrade temperature increases oxygen consumption by 13%. So, in those patients having CNS, pulmonary or cardiac comorbidity, reduction of the fever by antipyretic is very, very important. Sometimes in hyperpyrexia, cold blankets are very important, but not without antipyretic. First we have to give antipyretic, along with that we have to use cold blanket. So, if we summarize the treatment and treatment regimen, we have to understand where we should use antipyretic judicially. We have to understand where we must use antipyretic. We have to understand what is the mechanism of antipyretic. If we summarize as a whole, fever is a topic where lot of aspects we have to investigate, we have to cultivate, and we have to know. Thank you very much. Next episode we will be discussing fever with rash. Thank you very much.